All right. Good morning and welcome. This is our White House Summit on strengthening the nation's early warning system for health threats. I'm Matt Hepburn. I'm a senior advisor on pandemic preparedness at the White House Office of Science and Technology Policy. And I am absolutely thrilled that each of you in this room is here and has traveled to give us your insight today on how we do better and how we solve this complex problem of getting early warning, predicting the future, and forecasting. Some of you have traveled far and wide. Dr. Ann Zink from the state of Alaska, we should highlight as we sometimes do at weddings, the furthest traveler. But there is so much energy and enthusiasm and insight and wisdom in this room. I am absolutely thrilled to work with you today on how we solve this complex problem. We have a broader audience, of course, where actually thousands are live streaming with us, and we welcome you. We say good morning to you. We know we have our American friends on the West Coast and the Southwest and Texas, and we give you a good early morning welcome. Grab a strong cup of coffee. It's going to be a great event. You're going to love it. We also welcome our international colleagues. So we say good day, sometimes good evening. You are most welcome in joining this conversation and helping us solve this, again, complex problem. And most importantly, it's a thank you to all of you, those in this room, everyone listening on the live stream, for the things that you are doing every day to fight this pandemic. I think it's very helpful in all of these types of events for us to reflect a little bit on the ongoing suffering, the personal tragedy that we're all experiencing with this pandemic. And we pivot that to resolve. It's a resolve to be better prepared in the future. And that's what we aim to accomplish today. Because we have a contention. The reason that we are assembled here is that if we are able to forecast, predict the future, get a better anticipation of what's going to happen next, then that will enable our responses in the future. How do we do that? Predicting the future, extremely hard. But we can. I'm firmly convinced that we can do better. And it's because of the collective experience in this room. And it's because of the collective partnership of all those that are listening on the phone. It's both an American and a global solution for us to make that possible. So we have a great event today. We are actually starting with 4 senior leaders in our United States government. They are the leadership that can make this vision of forecasting into a true reality. We're going to hear their insights. We're going to get a couple questions for Dr. Walensky, and then we're going to proceed on through 3 panels and wrap up for the day. Now, for those of you listening in, we are not taking questions live stream, but we do want to hear from you. We have an email address. We will make that available for everyone that signed up to participate. Send us your thoughts, comments, suggestions, especially your insight, especially how we can solve these problems and do better. As a reminder, this event is recorded. So especially everyone in the room, this is recorded. So just so you know, I say again, this is recorded. But we do want you to be candid. We want you to share your best insight with us. That's how we're going to solve these complex problems. So let's get started. I'm absolutely thrilled because we are actually kicking off this event with my leader at the Office of Science and Technology Policy. I want to introduce to you Dr. Alondra Nelson. Dr. Nelson is the head of the Office of Science and Technology Policy and Deputy Assistant to the President, leading 6 OSTP policy teams in their work to advance the Biden-Harris administration in our priorities on science and technology. Dr. Nelson served since day 1 in the Biden-Harris administration as the Deputy Director of the newly created OSTP Science and Society team. She's a renowned scholar in science, technology, medicine, and social inequality. And she has served since 2019 as a professor at the Institute of Advanced Studies at Princeton. Before that, Dean of School of Social Sciences at Columbia University. Dr. Nelson.
applause for all of you for being here and for the work that you're going to do today. Good morning. Thank you all for joining us. Welcome to the White House. As Dr. Hepburn said, I have the privilege and honor of leading the White House Office of Science and Technology Policy, where our goal is to maximize the benefits of science and technology to advance health, prosperity, security, environmental quality, and justice for all Americans. I want to make a few remarks to begin, but I want to begin first by thanking the teams who put this event together, particularly Matt Hepburn, Carly Cox, Tanisha Carino, Andrew Hebler, and our colleagues at the CDC. It's been a wonderfully, beautifully collaborative effort, and they've been working very hard, and we're all tremendously grateful. So 7 years ago in this building, and one room and a room just down below this floor, a floor below us and a couple doors down, a group of experts came together to take a long view and imagine a future that could be. Like us, they were from OSTP, the National Security Council, the Centers for Disease Control and Prevention, and other federal agencies, also people from outside of the government, experts who specialized in pandemics and public health. Having spent the prior year and a half working together to grapple with the Ebola crisis, they paused to draw lessons from that experience and to ask, how can we do a better job of forecasting when an outbreak will become an epidemic or a pandemic, including where and how fast it will spread, so that we can be better prepared and indeed so we can save lives. They had a forward-thinking vision of what science and technology could make possible, a vision that emerged from experience and evidence, a vision that led to the center we're launching today. And it's a vision that President Biden deeply shares. In a letter the president issued just before taking office, he asked, what can we learn from the pandemic about what is possible or what ought to be possible to address the widest range of needs related to our public health? Being able to have real-time analytics and forecasting of infectious disease threats is exactly the kind of possibility the president was referring to. It is one of the many science and technology innovations that we at OSTP are committed to advancing for pandemic preparedness, including through the Pandemic Innovation Task Force, which is identifying and accelerating new solutions for both COVID-19 and future pandemics. We're grateful to co-lead that task force with several colleagues and agencies here today. The Center for Forecasting and Outbreak Analytics and its team of researchers, data scientists, and more will help transform US and global capabilities so we can stop outbreaks before they threaten the world. And their commitments to scientific analysis will strengthen our systems to not only deal with this pandemic and future threats, but also improve everyday health for all Americans, both in crises and equally important in ordinary times. This center will be a national asset. That's why epidemic forecasting and modeling was included among the first actions directed by President Biden via his day one executive order on strengthening the response to COVID-19 and leading the world on global health and security. It is also a key priority in the American Pandemic Preparedness Plan that OSTP and NSC released last fall, which makes today's launch a promise kept. Making accurate forecasts start with gathering different kinds of data from varied sources. A few short decades ago, we weren't great at forecasting weather beyond a day or two. As a result, lives were lost to powerful storms, crops were ruined, ships sank, and property that could have been secured was destroyed. But because we work to understand how weather affects communities and vice versa, and we have made transformative science and technology investments in data, in computational power, and in infrastructure, another vision is possible. From ocean buoys equipped with sensors that can measure waves from an oncoming storm, to satellites in orbit, to weather stations around the globe. Because of all of this, we now have at our fingertips weather forecasts that can help us manage risks and be ready. When we look at infectious disease forecasting, we are truly in the early days. But today, as before, science and technology can help make the difference, help us be prepared, and help us save lives going forward. And with the right investments, we believe these aspirations can be achieved. To be clear, it won't be exactly the same as weather forecasting. The weather forecast even isn't always right, And human behavior makes infectious disease prediction fundamentally different from and harder than weather prediction. But while disease models are imperfect and inexact, they are still incredibly powerful and useful. This center will allow us to more clearly see threats on the horizon so we can inform public health decisions and prepare accordingly. Ultimately, it will seek to draw on data from across all of America to help protect people across all of America, because this should truly be a national asset with equity at its core, so that public health officials and federal, state, local, tribal, and community leaders all across America and all across North America can make smart policy decisions, and so that all of the American public can be informed and ready. Returning to President Biden's question, what can we learn from the pandemic about what is possible and what ought to be possible to address the widest range of needs related to our public health? Another lesson is that trust in government and in science are enabling conditions for innovation. And building trust will be key to this center's data and analyses, helping as many people as it aspires to. Because while we're now at a point where scientists can begin to make forecasts, those forecasts must be trusted. A storm warning has limited value if an evacuation order goes unheeded. We especially need to build trust with vulnerable and historically underserved communities, including communities who've been disproportionately affected by COVID-19. Government and public health officials have to build that trust every day, and it starts with better information clearly communicated. It's going to take all of us to realize this promise, which is why I'm calling on the broader science and technology community today to help the team at the Center for Forecasting and Outbreak Analytics to succeed. We are going to need, both in government and outside of it, more data scientists to help build the analytics and help us have more complete data, more software engineers to write code, more environmental scientists and engineers to build new kinds of data gathering sensors to monitor for airborne pathogens, sanitation engineers to help collect and track wastewater data, user experience experts to create platforms and portals to communicate and share data to varied communities, behavioral scientists, social scientists to help government and public health officials build trust in these forecasts, and so much more. This will be an ongoing effort of discovery and refinement of new data science techniques and computational tools, coupled with new opportunities to collect more accurate and complete data. Let's ensure that this center is indeed a national asset, equipped with the most cutting-edge thinking and innovations. To everyone who's been working toward this day since that meeting upstairs in 2015, congratulations. We're grateful for your vision and for your commitment. I know it's taken many years, too many, and for some at tremendous cost, but there's no doubt that your forecast that day several years ago was accurate. We needed and will continue to need new tools, new forms of expertise, and wider sources of data, the ingredients of any accurate forecast. Because when the next outbreak occurs, we must be better able to see the horizon and better equipped to save lives. The American public deserves nothing less. This is possible, and the center we launched today embodies that possibility. Thank you.
Great start. Thank you, Dr. Nelson. That was just wonderful. Next up, we have Mr. Jake Sullivan. I guess I'm stating the obvious a little bit. Mr. Sullivan is Assistant to the President for the National Security Affairs. Also in the Obama-Biden administration, he served as Deputy Assistant to the President and National Security Advisor to then Vice President Biden, Director of Policy Planning at State in the United States Department of State, and Deputy Chief of Staff to the Secretary of State Hillary Clinton. We are deeply honored to have Mr. Sullivan join us. Mr. Sullivan.
Hi, everybody. And thank you very much for giving me the opportunity to be here. It's actually quite humbling to be sharing a podium and a stage with some of the country's most talented and thoughtful leaders on science, public health, and social justice, including Alondra, Ashish, Rochelle, Matt, and so many others here. And being able to come to work every day in this company, the folks around this table, is what really keeps me going, and I think keeps all of us going. So this is just a great day, a great initiative, a great effort. And I'm delighted to be here to help mark the launch of this new Center for Forecasting and Outbreak Analytics. As the pandemic unfolded in 2020, I know so many of the champions in this room helped make the case that the United States could do better at a lot of things. And that, as a country, as a government, as a public health ecosystem, we needed to modernize our efforts on how to forecast how viruses, starting with this virus, the COVID-19 virus, would evolve and who is most at risk. We needed to better understand what was coming around the bend so we could better target our responses in real time and help lead the world in strengthening pandemic response. And the leadership of everyone who's gathered here today and so many more has been essential. And especially to Dylan George, to Beth Cameron, to Topher Spiro, who worked so hard to make this center a reality and who helped get it funded, which is probably the most important thing. On day one of this administration, President Biden signed National Security Memorandum 1, which we spent a lot of time branding. That's like National Security Memorandum 1 was like a really kind of hot name we decided on. Very elegantly named, we think. Okay, so not the best branding maybe, but it was a truly foundational document. This is the first national security memorandum coming out of this, even before we had even set up the structure for the National Security Council. And it showed the emphasis and energy of the president and the priority he placed on this set of issues. And what it attempted to do in concept was focus the tremendous capabilities of the US government, not only in getting a handle on the immediate crisis and the virus we were facing, but advancing global health security and biological preparedness for the next outbreak and the next one. It enshrined the creation of the Center for Forecasting and Outbreak Analytics. And it stated that the administration would treat epidemic and pandemic preparedness, health security, and global health as top national security priorities. And, that for me as National Security Advisor and for the entire national security apparatus of the government means not thinking of health as adjacent or, a companion to the work we do, but as literally central and critical to the work that we do. And we see the implications and impacts on national security across every dimension in the world of COVID-19 and of what it would mean for us to get ahead of the next pandemic effectively, how much that would strengthen the national security of the United States and the overall security and stability of the world. I realize to this community, all of this sounds kind of like, well, duh, very obvious, maybe not a big deal, not a grand revelation. But beyond this community, across the fullness of the US government and all of our partners and allies that we work with around the world, this was a historic recognition in National Security Memorandum 1 and in the way that we have structured and set up the work of the US government, the work of the National Security Council. And over the last year and a half, and going back all the way to the beginning of the pandemic, the twin health and economic crises of COVID-19 have really shaped our approach to world events, to global trends, to the structures of international cooperation. So much has been thrown at, and so many people in this room have been working 24 hours a day just to deal with the immediate. But you somehow found extra hours, I'm not exactly sure how, to build this stronger foundation to effectively tackle and prevail against the longer term challenge that all of us face. And that's what this center that we are launching today is really all about. It will expand US capabilities for sharing and integrating data for public health action. It will support innovative research in disease forecasting and analytics with a fixed eye to protecting members of the most vulnerable communities. And critically, it will emphasize communicating those results, the results of these models to decision makers. So we're not just generating data, we're not just generating analytics and forecasting, but we're actually getting it to the people who need it so that it is truly actionable And that's true not just at the federal level, but at the local, regional levels as well, and to international partners across the world. We have seen the devastating effects of the COVID-19 pandemic on human life, on livelihoods, on economies, on communities, on the resilience of nations, on the vitality of our global community. And what the current pandemic has made excruciatingly clear is that we have to do better as we go forward. And that's part of why the president requested a historic investment in pandemic preparedness and biodefense in the FY23 budget, $88 billion across multiple departments and agencies, including nearly $6 billion over 5 years for the CDC for early warning and situational awareness, both at home and around the world. And the president will continue advocating for funding for transformational improvements in our capabilities to prevent, detect, and respond to emerging biological catastrophes. Now, one other thing that National Security Memorandum 1 did was direct the National Security Advisor, the role I currently occupy, to review the current landscape of health security policies, to take a look at everything that we are doing from the point of view of integration and coordination. And I'm proud to say that we have completed that review, and we are finalizing a new national biodefense and pandemic preparedness strategy. This strategy will increase our capabilities for a wide range of biological threats. It will help reinstate the global norms against the development and use of biological weapons, norms, frankly, that we see are threatened every day. And these plans that we are putting together, the work that is built out of this review, will build upon the American Pandemic Preparedness Plan that OSTP and NSC put together and released in September of 2021. That document laid out a vision to transform American pandemic preparedness, and now the official national strategy on biodefense and pandemic preparedness will build on it and truly give the entire US government and beyond a touchstone upon which to pursue our efforts with common purpose and with as effective coordination as we can possibly muster. So with that, I just want to say I'm delighted to be part of today's events, officially launching the center, knowing the capabilities that it has, what those capabilities will inspire, develop, and unleash, and really just to frankly bask in the passion and the commitment and the smarts and the talents of the people gathered in this room. And I just am really proud to be your teammate, proud to be a part of this effort, and I look forward to working with all of you as we take this really important work forward. So thank you very much for giving me this opportunity.
Again, wow. We were off to a great start here. Next, I want to introduce Dr. Ashish Jha. We should welcome him to the White House family. So, and is now the White House COVID-19 response coordinator and counselor to the president. Prior to taking this role, Dr. Jha was the dean of Brown University School of Public Health. And before that, he was professor of global health at the Harvard T.H. Chan's School of Public Health and director of the Harvard Global Health Institute. Dr. Jha.
Right. Good morning, everybody. I'm going to try to keep my remarks really short because you're here to listen to the scientists and the folks who've been doing this extraordinary work over the last period of time getting this center launched. What's been interesting in this pandemic, really from the early days, has been the mantra that we all have been shouting, that we've got to follow the science. And if you dig one level below that and ask, well, what does that exactly mean, follow the science? Because everybody agrees we got to follow the science. It means we want to follow data, we want to follow evidence, we want to follow that data properly analyzed to inform both where we are and where we are going. And, as we approach the 1 million deaths mark that we are going to hit at some point in early May, the failure to have that data, the failure to be prepared is really stark. Right? 1 million Americans have lost their lives to this. And of course, the economic devastation, all of that has been profound. The response from our leadership, our public health leadership, has been to scramble, to pull together evidence, to try to make the best decisions we can. And I would argue we've done a pretty good job but it's also been really clear this is no way to run a response to a pandemic. And that's what this center begins to do, both for this pandemic and for future ones. It puts us in much more durable and much more effective setting to manage these kinds of crises that all of us understand we're not out of this one, and we will face future ones. The center also does something else that's related that I think is a bit different, and let me just kind of make the point about it. I think about where we are in this pandemic, right? There's a lot of misinformation, there's a lot of confusion, but there's also reasonable people who disagree on policy. People of good faith who think we should do a little more of this or a little less of that. And that's fine. That's actually good and healthy in an economy, in a country, in a democracy. The problem is that we struggle to understand the problem here is that we often don't begin with the same book of facts, right? So this morning when I walked out of my apartment to come down here, it was 41 degrees and it was sunny. And I looked, no rain in the forecast. You guys have all heard the weather analogy, but no rain in the forecast, 41 degrees. I chose not to wear a coat, a decision my mother would be aghast at. But I made a choice based on data. And there was no disagreement about whether it was 41 degrees or not. And pretty high degree of agreement that it wasn't going to rain today. That's fine. As a society, we can make different choices. The problem has been that we don't even begin with the same book of facts. We fight about, is it 40 or is it 80? Is it raining or is it sunny? And policymaking in that context is nearly impossible. And that to me is going to be a major contribution of this center. And so I feel like we are embarking on a process that will put us in totally different footing for the rest of this crisis and future ones. Let me just make a couple more quick points and I'll wrap up. As Dr. Nelson said, this idea has been around for a long time, started 7 years ago in this building. There are a lot of these ideas that float around in Washington. Really, really good ideas that never end up coming to fruition. And this one has. So let's take a minute to talk about why it has. One is the leadership of this president who has made this a priority. President has a lot of demands on his time and on his priority list, lots of people who want to put other things on his priority. And he's made it clear that this is one of his top priorities. And that's why this got funded and has been his leadership. But the funding and the leadership of the president is really important, but not enough. And I want to just take 30 seconds to talk about the leadership of somebody else who took that and then ran with it to bring us to where we are today. And that's Dr. Walensky. If you think about what good leaders do, what great leaders do, they identify really important topics. They find the best team in the world to go execute on it. And then they get out of their way. That's more or less what Rochelle has done with this. When I remember the day, I think it was on Twitter, I assume it was on Twitter, because where else do I get any information, that this was announced and I heard who was on it. And I remember thinking, oh my God, the dream team. That's right. That dream team. It is the dream team. And so to the dream team, thank you for your extraordinary work. And to Dr. Walensky, thank you for your leadership in getting us here. So today is the launch of the next phase where we make sure that the rest of this pandemic and future ones are responded to and predicted and worked on much more effectively. And that is the most important path that we can take to making sure that we save lives, we protect livelihoods, and get our country back again. Thank you all very much for being here today. I could not be more proud than this moment in terms of getting this center launched. Thank you.
So good. Let's keep going. Next, I'm pleased to announce Dr. Rochelle Walensky. She is the director of the Center for Disease Control and the administrator of the Agency for Toxic Substance and Disease Registry. Dr. Walensky served as chief of infectious diseases at the Massachusetts General Hospital and a professor of medicine at Harvard Medical School. On a personal note, I think a thank you. I think in life, people don't say thank you enough. I think thank you, Dr. Walensky, for your public service, for your commitment daily to fighting this pandemic. Dr. Walensky.
Thank you, Dr. Hepburn, and good morning, everyone. What an exciting day this is to be officially launching the CDC Center for Forecasting and Outbreak Analytics during this summit, strengthening the nation's early warning system for health threats. Indeed, strengthening the nation's early warning system for health threats is exactly what this new center will do. Bringing together next generation public health data, expert disease modelers, public health emergency responders, and communication experts towards never facing a public health emergency unprepared. Creation of such a center has been among my top priorities since becoming the CDC director in January of 2021. The COVID-19 pandemic has demonstrated the resilience and commitment of the public health community, while also exposing the many gaps from the decades-long erosion of the US public health infrastructure. The need to focus on health equity, the need to invest in an upskilled public health workforce and in our laboratory facilities and capacity, the need to make sure our data are standardized and move faster than the disease itself, and the critical need for investments in preparation of future health threats, both global and domestic. Now, thanks to Congress and funding from the American Rescue Plan, we have the resources to help us respond to COVID-19 and to public health challenges that are certain to follow. Funds have been awarded to state and local jurisdictions to support public health staffing in areas of greatest need, including community health workers, laboratorians, doctors, advanced practitioners, and nurses in hospitals, in home care, and in our schools. This includes a $3 billion grant to build a public health workforce that is culturally competent and representative of the communities in which they work. We're launching Public Health AmeriCorps to develop a new workforce ready to respond to the public health needs of the nation and to provide public health service in their own communities, opening the door to a public health career to the next generation. And we have $200 million from the American Rescue Plan to build the Center for Forecasting and Outbreak Analytics, CFA, to help us prepare for future health threats, both global and domestic. CFA will be there with analyses at every stage of a health threat. Early on, the center will determine the outbreak risk and its potential to reach epidemic status. Later, the center will be able to weigh the expected impact of alternative interventions and help jurisdictions decide where to direct their resources. In this way, CFA will help reduce the clinical burden and mortality while diminishing the potential for social and economic disruption during health threats. Equity is a core principle underlying everything we do at CDC and everything the CFA will do. In fact, we've already awarded $26 million to academic institutions and federal partners to advance modeling and forecasting methodology with an emphasis on diverse workforce development and health equity, including having health equity experts at the table and on staff, bolstering the expertise that already exists across the agency. And although there are many different sources of data, many of which we at CDC don't control, we also know that part of the reason that health equity hasn't received the attention it deserves is that sometimes the inequities are simply invisible. The data are just not there to illuminate the gaps. And CFA will make a priority to identify and help highlight those gaps as a means to drive change and innovation. The work of CFA will fall into three main pillars: predict, inform, and innovate. The predict team will generate forecasts and analyses to support epidemic preparedness and response. The team will model and forecast disease transmission and produce analyses, evaluate forecasts and other analysis produced during an outbreak to assess performance, establish and maintain data and analytics technology architecture, and collaborate with federal, state, and local leaders to support decision-making. The team will be staffed by experts in infectious disease modeling, epidemiology, and data science. The Inform team will share timely information with federal, state, and local leaders and the public. The team will translate and communicate forecasts and analyses to support public health decision-making, maintain a network of engaged decision makers, and build capacity at the state and local level to produce and interpret model and analytics, establishing those where local data will need to drive local decision-making. And finally, the innovative team will advance research and development priorities to improve the performance of outbreak forecasts and analyses. The team will identify and enhance data sources and studies in collaboration with public, private, and academic partners, support development of new methods to make accurate, timely, and useful forecasts and analyses, establish a network of innovative hubs to design, build, and test novel analytics and data sources, and advance communication and visualization capabilities. And in just a few short months prior to this official launch, CFA has already proven its value. During the pre-launch phase, CFA helped us anticipate the timing and impact of Omicron, something we would have never been able to do without CFA. Very early on, we saw that Omicron had the potential to cause a large resurgence. The things we needed to know were the characteristics of the virus and how well our countermeasures would work. We needed to know its transmissibility, its severity, and also its ability to escape our vaccines and other forms of immunity. Our first case was detected in the United States on December 1st, and by January 1st, 95% of the cases in the United States were the Omicron variant. I asked CFA to help us understand Omicron's impact, and the team immediately began working with Kaiser Permanente, Southern California, to analyze the severity of Omicron compared to Delta. Now, this may appear like an easy question, but the analysis had to control for prior disease and when it occurred. It had to control for prior vaccination and when the doses were given. It had to control for underlying comorbidities. It had to control for testing history. So finding the right colleagues who could even conduct this kind of study was not an easy task. Their findings together swiftly showed that Omicron would be less severe than Delta. For example, they found that the Omicron cases had 60% less chance of hospitalization compared to Delta, even when controlling for all of the other factors above. Those who were hospitalized had an average length of stay of 2 days with Omicron compared to 6 days with Delta. This corroborated what we were hearing simultaneously from South Africa, where the variant had first emerged. And shortly after the variant's arrival here in the United States, we were able to alert the public, health leaders, and our other partners, providing advance notice of the timing and magnitude of the expected surge, as well as the severity of the disease itself, allowing both the US government and our jurisdictional partners to actively advance plan. Also, during the pre-launch phase and in collaboration with academia and the Office of the HHS Assistant Secretary for Preparedness and Response and the modeling team there, CFA provided analyses on school test to stay policies, on travel policies, on vaccine policies. Asper O'Connell and her team, thank you for your partnership. We look forward to building and growing together. And while I'm acknowledging stellar individuals, I want to particularly thank Mark Lipsitch, Dylan George, Caitlin Rivers, Rebecca Kahn, and Allison Kelly for their extraordinary work to get CFA to this point. They have been, as they frequently say to me, a very small but very mighty team. I will add a brilliant team who have done so much work already. And whose expertise and talent are going to drive us toward growing together in this exciting next chapter. And all of this is just the beginning. We will develop a program to provide insights about infectious disease events for the public and work closely with partners across federal government to fortify preparedness capabilities. Beyond our initial startup funding from the American Rescue Plan, CDC is requesting $50 million in annual appropriations in fiscal year 2023. In addition, the administration has proposed the Pandemic Preparedness Plan, which includes $5.91 billion over 5 years for CDC for early warning and situational awareness, including domestic and global threat detection and the Center for Forecasting and Outbreak Analytics. CDC has a long history of using modeling to guide our decision-making. Modeling and analytics are playing an ever increasing role in outbreak response, and the need is only going to grow. CFA will continue to focus on saving lives and protecting people through outbreak data, forecasts, and analytics, making data analysis and scientific methods open to the public in human and machine readable formats as much as possible. CFA will work with partners, those in the public sector, the private sector, and in academia to coordinate efforts and maximize our impact. These bonds are already being fostered, and CFA will support efforts to achieve health equity by using data to identify and track health disparities in outbreaks and inform policies to actively address those disparities. So as I said when I opened, this is an exciting time, one long awaited by me and by so many others. This new center has the potential to improve lives, to save lives in ways we can really only even imagine at this time. I am thrilled to look forward to watching it grow, to thrive, to excel, not just for CDC, but for all of America and for the world. Thank you so much for joining us today.
I'm so excited. It's just incredibly inspiring to hear there are 4 speakers. I mean, again, these are the senior leaders of our nation emphasizing this, telling us we can make this a reality. In all of these meetings and events, I love the questions, right? This is why we get together and this is why we talk. So Dr. Walensky, if you're amenable, we're going to take a couple questions. What we're going to do is 2 things. So if you have a question, if you can turn your place card up on its side, or if you want to just raise your hand, that's fine too. I will remind you to press the button by your microphone when you ask a question so we can hear you, and also our colleagues that are live streaming. I am usually that guy that forgets to press the button, and I probably will. We'll forecast about a 40% chance, but I strongly remind you to press the button before you ask questions. So we have time for a couple brave souls around the table who would like to ask a question. Yeah, Raj, why don't you start? Thank you.
Well, thanks everyone for and Dr. Walensky for your inspiring remarks. You mentioned the vision of ensuring this data is available at the local level to address health inequities in response to future epidemics, and this one as well. And you highlighted one of those adjacent initiatives, America's Public Health Corps. I'm curious, how far does the vision go for ensuring that data is used at the local level? Does it reach all the way to those community-based health workers as well?
Thank you, Raj. Thanks for that question. I think it has to. I think that part of the challenge of this pandemic is we did not have public health workers, trusted public health messengers in the local levels. I will tell you, when I came into the administration, we were collecting data on race and ethnicity of about 38% of our testing in COVID. We were working hard to get our vaccines to social vulnerability, to places with high social vulnerability index, because we knew that those might have been places that were going to be challenged with the vaccines. And that was an extraordinary effort, perhaps harder because we didn't have people in public health at the local level. And so this is critically important. I firmly believe that if we had local public health workers in community-based organizations doing blood pressure checks and nutrition consults, that when it came time to vaccinate, they would have been trusted in those communities, and this would have been a much easier lift for all of us. So that, I think they have to be integrally linked, and the data have to come from those communities as well. They have to flow. Thank you.
Fantastic, thank you. Dr. Nelson, you want to go next? Or great, yes, please, Seema.
Thank you. Dr. Walensky, the point you just made now about there being perhaps a lack of that public health capacity at the local level, I disagree. And I would say there are established community health advocates, for example, that have worked on HIV for decades. And I organized a listening exercise at the White House last year, which you attended, to listen to those with lived experiences, even if they didn't have academic training in public health, given how important it's going to be to make sure the data from CFA is translated to a community level, to make sure we are engaging trusted communicators. What will CFA and CDC's overall approach be to engaging those with that lived experience and expertise?
Yeah, I think that that's a critical point, and one from my HIV background. When we needed community-based workers to help in contact tracing, we went to our sexually transmitted disease clinics. Those were the people who knew how to do the contact tracing. I came from a clinic that worked in HIV, and it was our community-based workers that brought in from the community the hardest hit and those who were hardest to find, who were on the front lines. And that's actually the vision of having public health workers. I'm really encouraged. Our applications to schools, our applications to nursing schools, to public health schools, to medical schools, to advanced degree schools are up. People have been motivated. As hard as this years have been for those of us in public health and in medicine and in nursing and in community work, there have been so many people who've leaned in, so many people who have volunteered their time to be contact tracers, to call, to get people vaccinated. So there is a pool of people out there who I think, I agree, we have that in HIV. We have not had that in all of public health. And so that's exactly what we're working to do.
There, I pressed the green button. So mission accomplished. Dr. Nelson, would you like to go next? And then we'll go to Dr. Hamburg.
Sure. Thank you so much, Dr. Walensky, for those incredible remarks. The potential of the CFA is just incredible, and I just am so excited to see what the work that the team will do. So I wanted to ask you about equity and about if you could say more. You said powerfully in your comments you talked a bit about health equity, and I wanted to hear a little bit more from you about how the work of the CFA you think will strengthen the Biden-Harris administration sort of commitment to not only health equity, but equity more generally.
Yeah, I think part of the challenge is we don't even have the data in some situations to inform health equity. I think we know, I will defer to my modeling experts, but we know that if you have sort of the holistic data from the United States, that doesn't speak to what is happening in a given community, how a given community is responding, what vaccine rates are in a given community, and we need the equity data. And maybe I'll highlight two areas. CDC just recently put out an MMWR on vaccination rates in our LGBT community. Now, one might or might not have thought that that was a really powerful and potent MMWR, but what I will say is we'd never had the ability to collect those data. So the fact that we were able to collect data on an LGBTQ community and was novel, actually. And I would say not only on race and ethnicity lines, we know now that our vaccination rates in our rural communities for our children are threefold less than in our urban communities. So we have work to do across all of equity, and we need the data inputs, we need the local data, because one might be able to run a statistical model with an average of the United States. But if we can parameterize it with data from a local community, that will inform local efforts. Thank you.
Great. We have time for two more quick questions. So Dr. Hamburg and Dr. Gellin, and then we'll let Dr. Walensky off the stage. Go ahead.
Well, thank you very much. And my question builds on the last one. But first, let me congratulate you on this accomplishment. I know how hard it is to get this kind of work actually done, and to have it in place and already demonstrating its value is an extraordinary accomplishment. I did want to sort of ask you to think a little bit longer term about how this effort can also help to strengthen data collection, analysis, and utilization more broadly, and inform, the other issues that matter for health. Certainly when we talk about equity, a lot of things spring to mind, but in terms of burden of disease across all populations, infectious disease threats are essential, but there are other kinds of changing patterns of disease that we need to track and understand in order to make better decisions. There are environmental exposures. There's other kinds of threats. My understanding is that this program really is focused on infectious disease threats. And as we, sort of come out from under COVID, hopefully, it is really important to build on the lessons learned and continue to respond to this unfolding pandemic. But does this, in your mind, ultimately represent a model for strengthening strategies for data collection and reporting, analysis, and use?
Absolutely. So we have a sister effort that is ongoing, which is our data monetization initiative that really is working to connect the pipes of data collection. And so CFA, I think, is keenly aware that they need to have really solid data architecture in our and in order to be able to make the best predictions, anticipate the best forecasting. So we are working closely at CDC on a parallel sister effort called our data monetization effort. One of the things that's actually really powerful about disease modeling, though, is that one can sort of use those models to anticipate what is the most influential parameter in this analysis. And if you determine that the most influential parameter is X, and one then realizes that you're not collecting adequate data on X, then you double down and make sure that those are the best data that you can collect. And so I think it's really helpful in sensitivity analyses to understand what are the most important data you can collect. How good are your data on that parameter itself? And then how good are the pipeline of data coming into you through our data monetization efforts?
So Dr. Gillen, very briefly, we are a little bit behind, but please, you'll have the last question.
Thanks. So we appreciate the opportunity to be at this launch. I know we'll all look back and see and look back at the trajectory. You've got a vision, you've got a dream team. You've talked about some of the resources you've requested. What are there authorities that you need that you don't have to be able to fulfill this vision? And as Jake told us, this is a national security issue. Do you have what you need both in terms of dollars and authority to expand this to have a global impact?
Thank you for that question. I could be pithy and say no. We don't have the capacity at CDC. We don't have the authority at CDC to have a full line of sight of the data that we need. We don't have the authority to collect it. We're struggling to ensure that after the public health emergency, we will have the authorities to collect the disease severity data, people who are being hospitalized. So we are working collaboratively. We want to work synergistically with the state and local public health authorities so that the data that we collect, we feed back to them. We collect it in real time with them. There are states that don't offer us their wastewater data. We collect it voluntarily. The data are not standardized. So a state would, a jurisdiction might give us data in one format and we might not get it in the same format from another jurisdiction. So there are real challenges in our data authorities. There have been many people through this pandemic who have demanded of us to publish something that we have no authority to collect. And so that, I think, certainly resources are going to continue to be a problem, both, or an issue, I should say, both in our data modernization efforts, as well as in standing up the CFA. But I will also say in our surveillance efforts, because one of the things that I think we are starting to learn through this last 2 years is, that X that I just said was the most important parameter, that's a surveillance data point that we don't have full line of sight of. And so we really do often need the proper surveillance in place in order to collect those data. So all of those are an issue.
So let's do another round of applause for Dr. Walensky. That was brilliant. We're a few minutes behind, which is my fault. So how you can help to make up is panel one, we're going to do the quick switch. So we're going to ask Dr. Walensky and Dr. Nelson to take seats around the table. We're going to have Dr. Rivers come up and sit in this seat. And if you're on the first panel, come on up. And ideally, we're going to time this, see if we can pull this off in 2.5 minutes. We'll see. That went really great. I do want to briefly introduce our moderator. We have just truly outstanding moderators for these three panels. I mean, these are three superstars. We're starting off with Dr. Rivers. I don't want to say much more than I think Dr. Jha really hit the nail on the head. They have the dream team that is really leading this Center for Forecasting, and Dr. Rivers is a critical part of that dream team. Most of the modeling and forecasting community, those that are out there on live stream, know Dr. Rivers. And how I know her, and I will always remember this, is that when she was at Virginia Tech and we were in an Ebola crisis, she boldly was able to collect data information and organize the community in various ensemble modeling. And it was in my opinion, it was actually fearless. She wasn't like, well, maybe should I share or not? She did this on her own. It was grassroots. It was initiative. That's the kind of person she is. And that's why I'm thrilled she's moderating this panel. Dr. Rivers.
Thank you. And thank you. Thank you. And thank you to everyone for being here today. We are so excited at CFA to be able to share this moment with people who have supported us and challenged us for years, honestly. And so it's really special to be able to share this with you all. We had an amazing first panel, and I'm excited to welcome an esteemed group of panelists here to usher us into the second act. For this first panel, I've asked our colleagues to reflect on the importance of strengthening our national capabilities around infectious disease modeling and analytics, and to highlight what the next generation of that capability looks like and what it will do for us. So I'm going to ask each panelist to share a couple minutes of remarks, and then we will move on then to question and discussion. Up first is Dr. Margaret Hamburg, Chair of the Commonwealth Fund's Commission on a National Public Health System, former Commissioner of the New York City Department of Health, and former FDA Commissioner. Dr. Hamburg.
Well, thank you very much. I know we're supposed to be brief, so I'll try to just give a few thoughts. And I guess building on my new role chairing this commission on a national public health system, to underscore why this is so important. We really do need national level leadership to strengthen and extend and modernize our data collection, analytics, and utilization in critical ways. And I think that our experience with COVID has taught us many lessons about what it means to have gaps in our data architecture, so that we cannot inform sound policy decision-making in ways that are critical to save lives and limit disease, and the importance of being able to benefit from lessons learned to better prepare for the future. For too long, we have neglected our public health data infrastructure in this country. And it is, an absolutely essential moment to undertake this kind of modernization, integration, and comprehensive approach. As Dr. Walensky was just saying, we need to think about it in terms of collection and reporting. We need to think about the quality and sophistication of analytics and how strong are our models, and are we applying the most innovative approaches and constantly innovating as we utilize our models and come to better understand them. We have to make sure that we have data systems that are not stovepiped and siloed, and that has been a huge hindrance in terms of, again, echoing what Dr. Walensky just said, but the siloing of data with a failure to standardize the data that's collected, to share it in a timely way, and to be able not just to share within public health agencies at the local, state, and federal level, which is absolutely essential, but also we have to engage other critical components of our overall health system. And we saw with COVID how important healthcare delivery system data is. So we have to really take an opportunity like this center provides to break down those barriers and create comprehensive approaches, and also recognize that there are many other components of government and the private sector that also need to be part of how we think about data. Because if we don't have timely and accurate and comprehensive data, we will fail in our efforts to both better recognize emerging problems and prevent them, but also inform our response. So I think we have to really support this effort and make sure that certain critical elements go forward. And we all have a responsibility in this regard. Adequate and sustained funding is absolutely key. A robust, well-trained workforce is essential. The ability to work across sectors to bring modern technology and innovation to the work, and this critical issue of identifying the critical gaps in authorities and supporting their development. Finally, two last points. The international engagement that Dr. Gillen brought up is absolutely essential, because these threats are not simply domestic in nature, but the international engagement is key to success. And we have learned over and over again in response to crises that systems that are going to work well in a crisis have to be practiced every day. And to try to stand things up in the midst of a crisis, as you've learned, Caitlin, with this, is much more challenging. And as we go forward, this kind of a program will enable us to be ready when a crisis occurs, but will be able to enable us to identify crises that might occur and prevent them from happening. Thank you.
Thank you for that. Looking forward to diving into those ideas more. Next, we have Dr. James Liu, CEO and co-founder of Helix. Helix is a leading population genomics company. And as part of the pandemic response, Helix partnered with NIH to stand up one of the largest diagnostic testing labs in the country. And they also partnered with CDC to enable national genomic surveillance and forecasting. Dr. Liu?
Caitlin, thank you for having us. And thank you to the CFA for, well, I mean, it's just a wonderful thing that this is getting set up today. As Caitlin mentioned, Helix is a leading population genomics company. As part of our pandemic response, we set up the largest West Coast diagnostic capability in partnership with the RADx program at NIH. And then we did some of the early work in setting up variant surveillance, genomic surveillance with the CDC, I guess in December of 2020 at this time. So it seems like a lifetime ago, pandemic time, but certainly only about 15 months ago. We're big believers in forecasting. Just at the very basic local level for us, the ability to leverage genomic variant data and use that to forecast our ability in the supply chain to manage diagnostic testing was essential for us to think about managing for the Delta surge as well as the Omicron surge, and essentially forward buying that supply chain so that we can continue to service during those periods. But even within our health system partnerships that we do day to day, we started reporting out analytics that we generate in partnership with CDC to help them manage the healthcare systems. And for many of those partners on the healthcare side, provider side, it's about how do you manage your labor force and workforce at a time of incredible stress. It's about managing your capital and your logistics as well. And so we've been very intimately involved in some of those efforts as well. And we are incredibly excited about the CFA's formation and the ability to leverage this data on a more global scale. I would say a couple of quick lessons from having really been in the trenches, as we've done a lot of public health reporting to all 50 states, both on the diagnostic side and on the variant side, as well as establishing quite a few public-private partnerships throughout the pandemic. And I would say, I just reiterate Dr. Walensky's comments around data modernization. I mean, 50 states, 50 systems, thousands of jurisdictions, each wanting individual reporting is unscalable for any organization. And so standardized endpoints and standardized architecture and data formatting is going to be essential. And one of the things that we saw, even with one of our local health systems, was that for them to get the analytics back on what was circulating in their region took 60 days from the public health reporting. In a fast-moving pandemic, 60 days is a lifetime. And so even the ability to return data back, very simply, like what is happening in your local region, because this is very much a regional pandemic, or was a regional pandemic, was essential for their operations. The second piece that we've found to be incredibly important has been data linkage and data around data sharing. And it has been important to understand what's circulating, but I think as the CFA's work with Kaiser has certainly shown is that linkage to clinical data on the clinical severity is essential in terms of understanding the true impact both to the economy, but also to the local healthcare providers. And so we've been doing a lot of work on that as well, and really focused particularly in populations which have been undersampled. And we're doing that work now with the Rockefeller, focused on some of these populations that have been both underserved as well as been most disproportionately impacted by the pandemic. And lastly, we do believe that the private industry has a real role to play here in terms of partnership, and both in access to scale technologies and being able to perform and access partnerships that maybe not be available to some of the public sector. And so we're really excited about our experience with working with government. We think we can really be a force multiplier, and we're excited to continue to explore those up.
Thank you for that. We'll go next to Dr. Mark Lipstitch, who I'm lucky enough to work with at the Center for Forecasting and Outbreak Analytics. Mark is the Director of Science, and he is also a Professor of Epidemiology at the Harvard T. Chan School of Public Health.
Thank you, Caitlin. It's a real pleasure to be here. As Ashish Jha put it very nicely in his remarks, the pandemic has really shown the need and the call for an authoritative, trusted central source of information and evidence on the state of the pandemic and where it's going. And at the same time, there has been an explosion of data types and also data sources and people sharing their views about the data, which has been counter to that trend. So I think one of the real reasons for the value of CFA is to bring together and bring some unity to those kinds of data. I want to talk a little bit about those now. There are all sorts of new forms of data that have become salient during the pandemic, from mobility to wastewater to large-scale genomic sequencing and use of big data from electronic health records. I think we've also begun to really understand the value of classic epidemiologic data of the very simple form that comes from random samples of the population that has been much needed in this country, and some other international partners have really shown the value of large-scale gathering of random samples of data. So bringing these kinds of data together into a common picture is going to be one of the really big challenges and exciting activities of CFA. Our goal, as has been stated already, is to equip decision makers with the tools to understand the consequences of decisions, and to do so by combining very high quality data, the best epidemiologic analysis, and a really robust technology infrastructure to support our modeling and do it at a very professional level, building on the strengths of what academic and other government modelers have done, but really trying to bring a new level of quality. With our partners at the Data Modernization Initiative, we're going to work very hard to extract more from the kinds of data sources that we already have, because there is much more that can be extracted through the ways that people have already talked about in terms of connecting the dots. But I think in reflecting on how we're going to begin to approach this, one of the striking things is that each of these data sources has different strengths and weaknesses, or at least limitations. So wastewater is really exciting and promising as a way of understanding the burden of disease without having to do active sampling of people. But wastewater doesn't really tell you who has it, it just tells you how many. So when we talk about health equity and the need to understand how a disease is affecting, an infection is affecting vulnerable people, we need classic epidemiology and the old-fashioned kind of data on top of wastewater so that we can combine the size of the measure of the burden with an understanding of who is really getting it. And I want to just pause on the equity issue, because many of the remarks really raised that, and I think it's helpful to start talking about how we're going to incorporate equity more into our efforts. One of the fundamental questions about equity is how many people are in each risk group. every pandemic has different groups that are at high risk of bad outcomes. And if we don't have the statistics to say how many of those people are there in Michigan and in Texas and in different age strata and different numbers of comorbidities, we can't prioritize vaccines. That was a very challenging exercise this time. So one piece will be just to assemble those data in advance. Another piece is going to be to use the models to really sharpen what it is we mean by equity. So in this pandemic, race, ethnicity, and age were the two biggest determinants of who had bad outcomes for different reasons. But that meant that trying to figure out whether to prioritize frontline workers or prioritize people of certain age group was challenging, and we needed math to figure out which would be the most equitable in terms of outcomes, not just in terms of inputs. We've also recognized the value of combining data sources, sequence data and clinical data, as we've just heard, are much more valuable together than separately, and of using the best approaches, causal inference and data science, to extract the most value from observational data that is what we really need when we're trying to understand how vaccines work, for example, in the face of variants and waning and all the things we can't see in a clinical trial. So we are now trying to recruit the best people to help us do that. We will have job announcements out shortly to start to fill our predict team and our inform team that you've heard about already. We really are excited about the opportunity to take this moment to expand our small but mighty team, as we've been calling it, into an asset that can really change the quality of our public health response.
Our last panelist is Peter Grant, lead of partnerships and collaboration at the new WHO Center, the Berlin hub, we call it at CFA, and we have the honor of meeting with our hub colleagues at least once a month. So very glad to have the international perspective. Over to you.
Thank you very much. Yeah, we don't have yet a short acronym like CFA. We're working on that, but it's the WHO Hub for Pandemic and Epidemic Intelligence in Berlin. So we've been established a few months ago. So we just, we feel very close to the CFA because we're going through the same growing pain of finding a building, which we now moved into, opening positions and so on. And essentially it's an institution that was set up with the generous support of the German government in response to the issues that we've discussed this morning. The few remarks I'm going to make are it's also a validation of how well aligned we are, because some of those topics have been discussed this morning. Peter Peart of Ebola and HIV fame is very keen on saying that every epidemic starts in a community and ends in a community. And it's a humbling reminder, and it's also why it's so encouraging to see the focus on vulnerable community being explicitly said in the setup of the CFA, because without this, there's no amount of advanced analytics, AI, or slot your favorite acronym that will help us move forward. Another point is we talked about weather analogy this morning, and so the US has 50 states, WHO has more than 190 member states, and we're trying to find analogies that would illustrates a little bit the coordination challenge, but also the potential. So the air traffic control is another analogy where you don't have a central entity worldwide that does air traffic control. Each country with their own means control their airspace, but there's data standards that have been established to exchange information from airspace to airspace. And there's an incentive to exchange information because we all want air traffic to be safe. So like all analogies, it's a very imperfect one. But it also touches upon the fact that we need to think probably a little bit harder about incentives. Some speakers have mentioned the Omicron variant episode in November. From a South African standpoint, doing the right thing didn't feel that good. And how can we change that going forward? When we think about the future of international collaboration as well, it will necessarily be distributed. And I think part of the difficulty will be to have the possibility to do sense making of a very disparate set of data that we will not assemble in one place. It's not an extractive industry. Countries will want to keep some of their data for good reasons, but there are some technology who allow this perusal, if you will, across data set and put in correspondent data set that are very disparate in this distributed context. Another thing is the momentum is waning or seems to be waning, right? In a large part of the world, life becomes a bit more normal, and there's a limited time to harvest the lessons for the past 2 years. So what's very encouraging for us as the WHO hub, and to see the CFA being established, to see HERA being established in Europe, to see the Gulf states just hiring their first CEO of this past month, is to see that there are institutions being set up to carry the work forward. And we have work to do because there's also been a flurry of innovations that took place over the past 2 years, and also a flurry of natural experiments that happen between country X doing this, country Y doing something else. And we have probably not fully harvested the information that's in there, which brings me to perhaps my second to last point. The second to last point is that comparatively with the field of medical countermeasures, the field of surveillance or epidemic intelligence has been underinvested over the past 20 years. And it's time that we perhaps put together a research and development roadmap for this field in collaboration with CFA and others. The last point is one that Dr. Nelson stressed in her speech about trust and the need for trust. There's no amount of technology investment that will overcome a deficit of trust. And trust, much like the capacity that we need for surveillance system, is something that needs to be exercised in peacetime. It's not when you have an acute crisis that you can ask someone to grant your trust. So we look forward to working with the CFA to foster this trust.
Thank you. I'm really looking forward to this discussion. We have limited time, so I think we only have time for about 2 questions, but I have some good ones teed up. First, this pandemic has taken so many twists and turns, and at every turn, we wish that we were ahead. We want to get ahead of the virus. And so, Dr. Hamburg, as someone who has seen so many parts of the public health system, I'm wondering if you can reflect a little bit on the value of being ahead of the virus, ahead of the curve, and what that would really mean for communities and for decision makers.
Well, the goal is, of course, to be as much ahead as possible, and the ability to find yourself in that position depends on building the systems to know where you are. And so that's why the work of an entity like CFA and strengthening data infrastructure in this country and globally is so critically important and time urgent, because we really have allowed a system that is so fragmented and so under supported to go forward, that we have not been able to provide the kind of analytics that are needed, and to be able to rapidly detect, respond, and the goal is, of course, to prevent. So I think that if we've learned anything from COVID, hopefully we've learned the importance of a strong, effective data infrastructure, and the importance of collaboration across sectors and across borders in order to strengthen our ability to understand where we are, where we're going, to identify unexpected emerging issues, but also to track and respond to issues that we can expect, including future pandemics.
I think the issue of tracking and really understanding where the virus is and where it's going really gets to something that Dr. Lipsitch touched on in his remarks. The public has heard so much about cases and hospitalizations and wastewater and genomic surveillance and all of these kinds of data that, as epidemiologists, help us to understand what's happening, but is maybe not always entirely clear what we do with it and why it's important. So can you talk a little bit about why we need this data and where the gaps are and how we're going to fill them?
Sure. I think that what we most need is we have a lot of legacy surveillance systems and a lot of new surveillance mechanisms that are not yet systems. I think we need to step back and take a more deliberate approach at designing surveillance for answering specific questions that decision makers have, decision makers including the public. And the right source of data for one kind of question is different from that for another. Often it requires connecting different types of data sources, as we've talked about before. And I think what CFA's job and the inform function in particular is going to be to take these hopefully redundant data sources, because we need more than one source to triangulate, because no data source is perfect, and give decision makers and the public actionable information. So that's our job, is to take all these different kinds of things that tell us different aspects of the situation and put them together as the analogy to the weather forecast. We want to know what the temperature and the rain is going to be. We don't want to know what the specific humidity and the barometric pressure are, unless we are that kind of person, which some of us are. But not when we're picking our umbrella. And I think that is a workforce issue, in the sense that we need to begin to create experts in the combination of pathogen genomics and epidemiology. Those are not two things, those are one thing now. We need to build connections between causal inference and mathematical modeling, because those are, to interpret the inputs to your models, you need to understand where the data come from. So I think those are some of the things that we can work towards to make the outputs less mystifying and more unified.
Can I just add to my answer also that in addition to the kinds of systems we're talking about today that are so critically important, that become the foundation for tracking and responding, we also, I think, as a problem is unfolding, need to really sort of sit down and think about what are the critical questions that we need to answer in order to develop sound, strong policy, and how do we get the data to fill those gaps in knowledge. And I think, again, we did not do a good job at that during COVID. There are lingering questions today that, had we started earlier to make sure that the right studies were being done, the right data was being collected, we would be in a better place. So I think, that we have to have, just as we have active and passive surveillance, we have to have systems for data collection, reporting, analysis, and sharing, but we also have to have a proactive strategy to identify critical data that is needed in a particular context or circumstance.
It's critical questions, critical data, and also critical stakeholders. So to wrap us up, Pierre and James, I'm wondering if you could just say a few words about how we keep the momentum going that has built during the pandemic, of relying not just on our traditional public health infrastructure, but really bringing in the range of stakeholders who contribute to good public health. So James, if you could start.
That's a complicated question to give a 30-second synopsis on. The beginning of the pandemic, if everyone thinks back to almost 2 years ago, it was an incredible flowering of collaboration. It was a time where everyone put aside individual incentives in many ways, and said we had a collective good, and we had to solve towards that. I think the question of incentives is the right one. Is how do you set up systems where you don't depend on altruism of parties anymore, but that they are collectively moving in the right direction because they are personally incented or the organization incentive in the right way. And I think that works for both public sector, for governments, for private sector as well, which is how do you create all the right hooks in the right places so that people want to move all in the same motion. That's a complicated question to put together, but I think we've shown in the last 2 years that we can do that there are structures in place that will incentivize data sharing, data monetization, and how we can kind of link all these things together. So I think it's going to be a little brick by brick as we go through it.
Short answer to an impossible question as well. And getting back to the logistics of how to make it happen. As we just moved to our new building, which is a wish I have for you very soon, we are dimensioned for 120 people at the WHO hub, and only 60 or roughly half of those positions will be filled by WHO personnel. And I think it's a testimony to the need to collaborate. And it's fully our intent to attract talent to come to work with us, because we recognize that we won't have access to this talent internally all the time, from academia, from the private sectors, from countries, from National Public Health Institute, because they are the front line of that, to keep the momentum going, and also to keep us honest in making sure that we are solving the right problems.
Thank you to our panelists. We have more great discussions ahead, so let's thank our panelists. Matt, back to you.
Okay, panel number 2, quick switch. We are running just a couple minutes behind, but we have a little bit of buffer at the end, so we continue to track. I do feel like this meeting should be about 37 hours because I mean, each person in this room is just extraordinary and remarkable. And we want to keep the insights going. So this is a meeting, but we want to keep the follow-up, keep the energy, keep learning from you. And I think our next moderator is a case in point. So our next moderator is Dr. Seema Yasmeen, Director of Research and Education at the Stanford Health Communication Initiative. Dr. Yasmeen has served as an officer of the famed Epidemic Intelligence Service, or EIS, at the CDC, and has been a critical voice in connecting the dots between health emergencies and the public as an Emmy Award-winning journalist, poet, and author. Like, wouldn't you just love to have a cup of coffee with Dr. Yasmeen? I mean, so interesting. Dr. Yasmeen, over to you.
Thank you. I'm a Brit, so it would have to be a cup of tea. But thank you for that kind invitation. I'm so excited to kick off this conversation. We're talking about enabling local governments, thinking about how better information can better inform government decision-making at all levels, talking about my passion, which is the role of communication in an effective public health response, and thinking about the need for trusted networks of communicators. And we are joined by 5 esteemed panelists with lived experiences and expertise on these issues. They have been in the trenches. They can show us their war wounds. And we're going to have an informal conversation because we want to really grapple with these real world challenges, share ideas, disagree with each other respectfully, because that's always an interesting thing to do. And I want to start with you, Mark, as CEO of Nashville Health. I study information inequity, and I map America's information ecosystems to show that information access is a social determinant of health. And by mapping the nation, my team is finding that information access is deeply inequitable. So it's not just about more data. It's not just about quote unquote better data. It's about what we do with this data and who has the privilege of access to it. So tell us about Nashville Health's approach to data analytic frameworks, and also tell us about your approach and what we and everyone in this room and CFA can learn about Nashville Health's approach to data translation in a way that makes meaningful impact at the community level.
Yeah, thanks, Seema. It's a really important question. You know, the thing that we've talked about today at length has been really rewarding to hear is health equity, and how, you know, this new CFA needs to be infused and informed by health equity. And we talk about data and information. I think that we have to recognize, you know, in the case of a new infectious disease or a new contagion, that there's a certain amount of fear and there's a certain amount of uncertainty that gets into the public, but we can't mistake that as public health experts, that gets into us too. And we tend to go back to tried and true data methods, tried and true statistical methods. But the issue with that is that we have to recognize that the areas that we gather those information from and those data from, they amplify those areas, but they suppress and give us blind spots in the areas where we don't have that information in those data. And so it's really important to recognize that. And sure, you have to have data. We saw in the pandemic how data informed disease severity and disease spread and allocation of resources to hospitals and staff. And you have to continue to have those bridges. But we've got to also understand that we even have a bias towards our own information that we collect. And that when you have a particularly new and frightening situation like a COVID or a new variant or a new infectious disease, you have to offset that reliance on the empirical data in front of you with some qualitative data into those communities. And how do you do that? The qualitative data is really just another way of saying you have to have human bridges into these vulnerable communities. The other piece to that, and that we recognize at Nashville Health, is that as you collect that kind of data, you've got to make sure that you have people within those communities. We had a COVID response review with Nashville Health that evaluated our response to the pandemic. And one of the recommendations that came out was people in the Black community, Latino community, did not have a really good way of translating what was happening on the ground back up to decision makers. And so those trying to build that in a crisis situation is really tough. So even as we talk about strengthening our statistical methods, we have to really be more intentional about having these human bridges, these qualitative bridges to maybe it's a social worker or a school counselor, someone from a faith-based institution that give us that lived experience. We can't forget that the whole point of us being experts is to have a practical application in those communities and being effective in those communities. So if we can do that ahead of time, the other issue with that and a benefit of that is that when you build those qualitative bridges, those are the same routes you might be able to actually get to a point of getting better quantitative data down the line, because you've empowered people from that community to act and to trust that their decisions and their thoughts will be heard. So I just would caution everyone to say that think about the practical application of it, but let's not forget that there's a practical application of qualitative data that we don't get out of our empirical data.
That's really helpful. Thank you for kicking off the conversation. Dr. Lynn Paxton, you came out of retirement after an illustrious career at CDC to lead Fulton County, Georgia's COVID-19 response. Thank you for your service. And you found yourself not only leading the county's COVID response, but having to cobble together data from a multitude of sources. And you had to translate that data, as Mark was mentioning, but not only for the public, but for policymakers drafting legislation. So tell us about that process, and also the fact that Fulton County and yourself, you came to be known for using data to inform an equitable public health response to COVID.
Yeah, thanks. Well, let me just start off by saying that no one is more surprised than I am that I ended up in a local health department. But in many ways, it has been, it's been life-changing for me and hopefully for other people as well. So yes, it's absolutely true. At the beginning of the epidemic, like many people, we didn't have a CFA. It wasn't there. That's why I'm so happy that CFA is coming. Thank you. So, we found ourselves, honestly, we were trolling the internet sometimes for data. And so one of our immediate things that we realized we needed to do was to improve our own sources of data. And so we now have a relatively robust way of looking at our own local Fulton County data, which it's really been crucial because just to say, and I'm looking at you, Sandra, because Sandra actually knows very well Fulton County and DeKalb County and knows that we are blessed with having a very diverse population. All from the north is very different from the south in terms of population, in terms of political bent versus economics. And so we have to learn that we have to deal with all that. And what helps? Local data. Say, like, in your neck of the woods, this is what's going on. So we have found that. But however, what we've all said, and this has come up many times in today's camp panel, data alone is crucial, but it's not sufficient. I can explain to a certain person, people till I'm blue in the face. It's like, oh, the data, and I can go like this. But if I'm not connecting with something that is meaningful to them, I might as well be talking to myself. So what I've been excited about is that, listening to the mantra today of the CFA, predict, inform, innovate, is like, yay. Obviously prediction, that's the whole point. So we, that's the data, we need that. But it was the informing, because that has been the single thing that has been the biggest challenge to us, in Fulton County and at the local level. What we found is, I think collectively as public health, we've done a lot, and we have literally saved lives. However, public health has also recently lost a lot of ground. I've stood back in horror, I'll say this, at some of the recent legislation that has come out in certain states. Legislation that specifically says you may not institute a mask mandate in schools. You cannot do this, you cannot do that. So I see that as a loss of ground. And why did that come about? Well, for many reasons, but I think that also it's a failure of our part to connect with certain segments of our communities. And so why am I so excited about CFA? It's because I think that this is it's a way to start building back to, getting the people to our public, our constituents, to understand that, yes, we've got data, get better ways of looking at it, to make it so that it is applicable to the person, that we are speaking to. And I think that's why I think that CFA is just so wonderful. And I was really happy when Dr. Walensky said that there's an entire team under the inform bit, that to working early with linking with people like me, at the lower levels, to be able to help our own constituents. So yes, I'm very excited about this, and I'm going to stop talking.
Thank you so much, Lynn. And you mentioned schools. We're very lucky to have someone with expertise on schools. Meredith, you direct New America's Justice, Health, and Democracy Impact Initiative, and you did remarkable things, facilitating quite large scale but local level collaborations with schools. So tell us about that approach, but also how you envision for the next pandemic, the next crisis, CFA adding to these kinds of efforts.
Thanks so much, Seema. It's a real pleasure to be here. Again, my name is Meredith Sumter. I'm a director at New America. And I bring the perspective of utilizing data and making it accessible and usable at the local level for desired impact. And about a year ago, New America, along with the Harvard Edmund J. Safra Center for Ethics and COVID Collaborative, pulled together a task force in support of the White House's Return to School initiative. We brought together about 74 national, state, and local level associations spanning public health, education, and epidemiology. And we came together to develop a framework, a roadmap that could be used at the local level by the community, by the schools, to make it safe at the school level for in-person learning. This required developing, not only making use of data, but developing organizational practices with that data for effective infection prevention and control measures at the school-based level. And what this looks like differs across communities. It differs across school buildings, but there is a need for utilization of data and best practices to enable effective decision-making across jurisdictions at the local level. So I want to go back and just honor the remarks that were made by my two predecessors. You can have great data, but if it's really just the scientists and the public health officials who are making use of that data, we're failing. You've got to make that data practical, usable, accessible in public settings. So we represent the school's perspective, and we brought in local public health, local education, parents, teachers, custodial staff, nursing associations. They all came together and converged on what was needed at the local level for them to be effective, enabling safe in-person learning for students. These same practices are applicable in our churches, in our carceral settings, in our local government buildings, in our businesses. And I think what was exciting for us is to, align with where the CDC was going and making use of that data, but seeing how there are these relationships that were newly formed at the local level between local public health, local education, and across also jurisdictions, so municipalities, county officials as well. They were all coming in together and developing channels of communication so that they were not only sharing data, but also utilizing the best practices and guidance of what do you do with that data to get the desired impact on the ground. So when we talk about informing, yes, I want to honor that. We absolutely need to be focused on informing, but also the innovation on the informing at the local level for practical impact. That's what I'm excited to see where CFA goes with that over the medium term.
Thank you. And on that point, Dr. Betsy Tilson, I'd like to bring you in as State Health Director and CMO for North Carolina Department of Health and Human Services. You've talked before about how your state has used data to inform an equitable response, this health equity lens. Tell us more about the mechanics of that, how that really works on the ground, and also what do you need from CFA to continue driving those kinds of efforts?
Thank you so much. This is one of my favorite topics, so I'm thrilled to be asked that question. And thank you all for organizing this day. It is very, very, very exciting. One of the pieces that's very exciting is as we think about preparing or responding to a pandemic, the states and the local governments have so much work to do to actually plan and respond, that building the data capability while you're trying to plan and respond and in 50 different ways is inefficient. So having the data piece be nationalized, standardized is going to be so helpful and allow for much more efficient and effective response. So we're not all building that. And because in North Carolina, not only did we have to build these capabilities, I'll talk a little bit about that, but then moving the data into action, which is really where we needed to be, and especially in action with an equity lens. And we did a huge amount of work on that. But thinking about some of the data capabilities that we built, some for preparing. So we partnered a lot with our academic institutions, did a lot of modeling. So some of our own modeling, and you ask how many modelers, you'll get 6 different models, or you'll get more, one more model than you will modelers. But it's very, very helpful. And that was very, very helpful to think through some of our policies and trajectories. We also have a very robust syndromic surveillance system across all of our health systems that we're able to rely on. And we have a growing capability of wastewater surveillance as well. So we have some robust surveillance, which helps us with the preparedness around operations and policy. But some of the magic really happened in part of our response, where we built an enormous amount of granular data around race, ethnicity, locality, down to zip code levels across the state. So we built that within our cases and our testing. So we knew what communities, race, ethnicity, locality, rural, urban, where was the burden of disease, which allowed us then to think about how do we deploy our testing vendors? How do we push our masks out? How do we push out PPEs? Who are our trusted messengers, in what communities, in what populations? We relied a lot on our faith communities as trusted messengers. So because the government isn't always the most trusted messenger, who are they? And then even when we would start seeing in one county, or even because our counties are very heterogeneous, in the census tract level, who are the trusted messengers? In that census tract level, we started seeing our cases going up, and how do we activate those trusted messengers? And then we pivoted that to our vaccine response. And not only did we have this, and we had great granular data in our vaccine, knowing race, ethnicity, age, and we were able then to overlay that with our social vulnerability index, knowing across the country, across the state, who was getting vaccinated, who wasn't getting vaccinated, overlay that with our SVI. And so we were able then to think about how do we deploy our vendors to make sure that vaccination is accessible? What community-based organizations and where do we need to activate to actually be doing the vaccine so they're trusted vaccinators? Where do we have vaccine deserts and we don't have providers who are actually vaccine providers? And let's work with our healthcare professional, our medical societies, pediatric societies to recruit providers in those vaccine deserts.
I want to ask you just for a bit more granular detail because I'm an applied epidemiologist, and everyone who knows me knows I'm obsessed with evidence-based public health communication because we practice evidence-based medicine, but not evidence-based communication for some reason, even though there is evidence out there to inform our comm strategies. You've done incredible things with trusted networks of communicators, but how? How have you done it at a state level? How have you gotten boots on the ground, even established who are trusted communicators, advocates, leaders in faith communities, just across the board? How do you do it?
Well, we did a lot of research up front. So we had a huge communications team who actually then went out, talked to people, surveyed people, an enormous amount of research of what are compelling messages, what aren't compelling messages, who are trusted stakeholders, who aren't. So we've done multiple times now of research within our communities to understand that. And then once we understood that, then we had very intentional partnerships. Again, we had a whole work group, our historically marginalized population work group, where we had broad representation from many stakeholders across the state.
It's that qualitative analysis that Mark was speaking about and the building human bridges and leveraging that lived experience. Thank you. We'll try and come back to this, but I do want to ask Dr. Joe Francis a question about the VA as Executive Director of Analytics and Performance Integration at the Veterans Health Administration. Thanks for being here as well. Tell us a little bit about how you at the VA have used surveys specifically to inform not just care for veterans, but also to inform communications.
So I want to explain a little bit why a guy from a cabinet level agency on the federal level is here with a community group. And I think part of it is understanding that VA is really embedded in communities. We have nearly 1,300 sites of care in all 50 states as well as overseas. We take care of 9 million enrolled veterans every year. These are veterans to whom we have a sacred obligation to provide services over their lifespan since they're discharged from the military. We focus on a relationship of trust with them, and we ground our system in a foundation of primary care. Also important for VA is we have incredible data assets. We have an interoperable electronic health record across our system. That record will soon be shared with the Department of Defense as we move with modernization together. And we've been posting, you can go to accesstocare.va.gov and see hourly updates on our COVID status, cases, deaths, the status of our employees. We're looking to post on that site the status of our hospitals because we figure we can be a canary in the coal mine and provide some quantitative data that supports people like Dr. Tilson. But very little of that is actually meaningful to the veteran. I have part of my office also does veteran outreach and surveys. We have both standard surveys as well as standing consumer panels. And we were really interested in the issue of vaccine uptake in our group. And what was surprising to us is veterans probably from their background, military background, probably lean a little bit to right of center. And maybe some of their attitudes towards vaccination in general are probably more red than blue. But uptake has been quite high in the veteran community. And a lot of them, when we actually asked them deeply about the factors, it was their relationship of trust with the healthcare system, primarily with their primary care provider. In fact, their #1 preferred source of information on vaccination was the primary care provider. Their #2 source was actually some of the information that we put out because they felt, again, because of the trust, we talked about this earlier, that you have to establish in pre-crisis moments, that they could come and get a straight story from us. And by the way, it's not Washington that matters. It's not people like me. It is the folks on the ground in the communities. I live in Wilmington, Delaware. I speak very directly with the veteran communities there and with the director of the hospital. They're in the clinics on the floors talking to veterans. There is no resistance to vaccination, and there's no resistance to even things like masking in our environment because of that relationship.
Thank you so much for sharing that. We have a few minutes left only, but are there any questions in the room? any suggestions, any challenges to our panelists? You want any more granular data from them about how they've been able to do? We've heard lots about trust, equity, and actionable data. I might ask you a question, Dr. Paxton. Since you did have that unenviable task of cobbling together so much data from various sources, on just a really basic level, are you hoping CFA can be that one-stop data shop?
That's the first thing. When I was first informed about the CFA, the phrase that came to my mind, it's not entirely accurate, was one-stop shopping. You know, it's because you know, to be able to have a trusted source is wonderful. So that is what I'm extremely excited about. But again, I just wanted to emphasize how excited I am about the fact that it's already being built in, that you will be working with the local health departments, because throughout the COVID epidemic, I've actually spent a lot of time calling my personal links at CDC to find out, to get information. My health commissioner for the state of Georgia also calls this person, and that's been really valuable. But to have that already set up as you know, sort of a mechanism already established will make our lives so much better, and also make my friends so much happier. No longer asking for information.
I'm sure there'll still be a little bit of that, but certainly I think we're all excited and inspired by hearing about your lived experiences, what you've seen on the ground, and just very excited about the potential for CFA. And really, I think what we've heard over and over on this panel is the need not just for more data, not just for better data, but equitable access to data, and data that really informs a meaningful public health response. So thanks to all of our panelists. Thank you.
We have world-class experts, and they're also good at switching quickly, which is amazing. I think, you know, this is just truly electrifying. It is so inspiring, and I'm so optimistic really about the future. And I think to state the obvious of what I feel like has happened today is we have 30 experts of a diversity of experience and persons and thoughts and culture and all of that. But look what happens when we come together, and we're really coming together. And I feel like that's happening today. This is a perfect opportunity to introduce then our third panelist expert, our moderator here. I would like to introduce again, Dr. Frida Lewis Hall, Senior Advisor, Black Coalition Against COVID-19. Dr. Lewis Hall has dedicated her career to advancing health equity and is a pioneer in ensuring health innovation and that the system meets the needs of everyone, especially the most vulnerable in our community. You are so qualified. The work you do is so important. You get now to bring us home with this third panel. Thank you.
Senior means something different these days. I'm happy to be here, and I want to thank everyone that has spoken before us and setting a stage for what I think is going to be an interesting closing panel. So I'm going to ask each panel member to speak just a couple of minutes on 3 issues. The first is I'll ask them to reflect for a couple of minutes on what the CFA can and should do to create the kind of partnerships and collaborations with healthcare systems that will, number one, ensure that the data is communicated in a timely relevant and effective way to ensure response. Two is to ensure that that information is shared in an ongoing manner so that there's preparedness for whatever might come, and that the system as a whole is ready to act in accordance with whatever new health threat emerges. And then last but not least, to think about how that partnership gets built to ensure that all of our patients have the advantage that is potentially provided by this incredible technology and scientific prowess. So I'm going to start with you, Dr. Richard Pfeiffer, Chief Medical Officer and President of Genesis. And I want to start with you because as the Chief Medical Officer of one of the nation's largest skilled nursing and long-term health care providers in the country, you've had an up close and personal experience recently, and would love to hear your response to those comments.
Well, thanks, Frida. Yes, up close and personal. It's been quite an experience. You know, Genesis has been the largest operator of nursing homes in the country with over 400 facilities in more than 25 states. Our experience is representative, I think, of the rest of the nursing home industry, although we are larger and have more resources. But our experience can best be characterized as having two distinct phases, and those phases are important to what we're talking about today. The first phase, right in the beginning, in early 2020, was characterized by the need to rapidly deploy an emergency operations framework almost overnight, largely in the absence of external information or guidance. We were hit hard and fast. 45% of our beds were in the first 5 states, the hardest hit states, in early 2020. And of course, we didn't have a playbook for the disease, but we didn't have time either. Our facilities went from no cases to widespread outbreaks nearly overnight, and this with a 20% case fatality rate. But what we did have as a large operator with significant resources, we had strong nursing, operational, and medical leadership. We had a culture of patient safety. And we had an ability to identify patterns and trends significantly before public health officials and academicians. So that includes outbreak patterns and sources, symptom profiles of infected patients, such as the high rates of asymptomatic spreaders or the unusually low temperatures in the elderly that signaled a new infection, the pros and cons of various testing strategies, such as the hazards associated with prolonged PCR turnaround times, and the effectiveness and ineffectiveness of various quarantine and cohorting practices. So we saw all this immediately, and we reached out to public health officials. We reached out to academicians to try to get that information out, to analyze it, and then promulgate it more. So that was the beginning, the first phase, which was the lack of external guidance. We had to figure it out on our own and then help the external framework guide the rest of us. But phase 2 was more chaotic. That began a few months later, and it was characterized by a plethora of public health guidance, a plethora of regulatory policy. You know what I mean, but you're laughing because you had a similar experience. Too often that was in conflict from federal to state, conflict from one state to the other, conflict within a state from the regulatory and the public health arms of government. So during this phase, many federal and state regulators, public health officials, and other parts of the healthcare system, healthcare partners, they decided to, air quotes, help nursing homes by solving their perceptions of the challenges from the outside rather than truly engaging us as partners. This is an important learning because that limited their ability to protect patients. So I'm going to share with you quickly 3 key learnings. First, CFA should engage providers as collaborators and important sources of insights, not just as recipients of data or guidance. This needs to be bidirectional. For example, the best cohorting and testing strategies merge theory with actual frontline experience. 2, we need to build a crisis infrastructure to connect providers, stakeholders, policymakers, regulators at all levels, and that has to occur in real time, and it can be messy because it can involve uncertainty. It can be before the questions are fully answered. But if we wait for solid conclusions from a provider and a patient safety perspective, it's too late. So we have to do it together. And third, for all this to work, that infrastructure needs to leverage pre-existing relationships and communication pathways built upon trust. So we need to flex those muscles before the next crisis occurs.
Thank you for that, and perfect seating arrangement, quite by accident, Dr. Mark McClellan, because as a phase two-er, right, executive director at the Duke Margolis Center for Health Policy at Duke University and former head of the CDC.
CMS.
I'm sorry.
Not sure CDC will take credit.
That's what I get for trying to read with my glasses not all the way up. So you were right in the middle of how to share policy, how to respond to some of the needs in the middle of the crisis. So let's talk about how CFA may help us get out in front of that.
Yeah, thanks, Frida. And it's great to be part of this very important event for CFA, for CDC, and so I'll talk about for the healthcare system as well. And Matt, thanks for the super enthusiasm. That's really impressive. So I had three main points I'd like to make related to Frida's requests on how healthcare can work together, how to make it more sustainable, and how to make sure it reaches everyone. I think you've heard today, and you all have seen, and Richard and others on this panel have lived it, just how helpful healthcare data has been in contributing to a more timely and effective COVID-19 response. That includes the hospitals and the healthcare organizations are reporting on cases and hospitalizations. It includes, as Betsy Tilson mentioned from North Carolina, healthcare providers reporting on who's vaccinated to help shape the public health response. By the way, in some states, that data has gone the other way, from states like Utah sharing information with systems like Intermounts. They can identify through their trusted providers how to vaccinate at-risk populations more effectively. We talked about the sharing of data on a previous panel related to genomic sequencing, which is now larger scale than it's ever been in regions around the United States, thanks to partnerships with labs and healthcare organizations, RADx efforts, and groups like Helix. And then on top of that, many healthcare organizations providing really valuable information about just what these variants mean for different populations. Richard touched on that a bit. We talked about Kaiser Permanente earlier. There are other examples of that too, but these are still not systematic, as you all pointed out. And there are ways to, I think, make it more systematic. I think the most important one, though, is to recognize that the nature of public health emergencies, I think, are really responding. And we saw that with the technology platforms, the biotechnology platforms that emerged in this pandemic. Number one was the ability to do rapid and reliable identification of a pathogen and the sequencing at large scale. So that's never happened before, within days of the SARS-CoV-2 original strain being identified. Second was the development of therapies, monoclonal antibodies first, oral therapies now. Should be a faster path to testing more existing drugs in the future, but a therapeutic side where healthcare involvement really matters. That's what healthcare is about. It's not just a pandemic that for months and months is not going to have, by definition, any medical response. And then obviously vaccines with the plan last fall, and sounds like the one that Jake Sullivan was talking about. Based on that coming out soon, we'll envision something like 100 days to get to large scale availability of vaccines. Well, none of that is going to work effectively unless there is a much tighter partnership between traditional public health and traditional healthcare to make the next surges about rapid development of data, to guide where resources should be allocated, and then to make sure that they're actually being used effectively to contain outbreaks. And so viewing CFA as maybe a partnership between CDC, CMS, IHS, federally qualified health centers, the VA, all of the other healthcare parts of our healthcare system we talked about earlier that share in these goals could make this more systematic. I know we talked earlier about how CDC and CFA in particular are worried about continuing access to data on local trends in COVID, hospitalizations, et cetera, after the public health emergency ends. Well, CMS, my former agency, has a shared interest there. Just yesterday in their going to get technical, inpatient prospective payment rule, inpatient prospective payment system rule, they propose continuing asking or really telling hospitals and other healthcare organizations to continue providing this data, not under a CDC authority, but under the CMS authority. Like, look, we need to know this now. We've got treatments. We've got the ability to help our healthcare organizations respond better. We want to keep our beneficiaries informed and updated on vaccines. We need the data to do that. And that's a national system that affects every hospital and healthcare organization in the country almost. So are there ways to build on that, maybe partner steps like that with a clear strategic response plan from CFA working with CDC on how are these data going to be used? Are they going to be able to make it worthwhile for these busy providers who are worried about another case surge translating into more hospitalizations, respond and manage their patients more effectively? Can it allocate these the tests, the treatments, the vaccine boosters, et cetera, that would be needed to the areas where they could be locally most beneficial? And then finally, I think this really fits well with some priorities at CMS and throughout our healthcare system, VA and IHS and elsewhere, to make healthcare more personalized, more home-based, more upstream and preventive. If CMS is undertaking efforts right now to do a better job of getting care out in the community, including early diagnosis of health problems, those chronic diseases that Peggy mentioned earlier, well, this whole strategy around what a future pandemic response could look like fits in very well with it. But it's going to take a new kind of partnership and a new recognition of the evolving role, thanks to biomedical technology, our electronic healthcare systems, and our healthcare system reforms, to potentially make the next surges in pandemics not about hospitalizations and ventilators and deaths, but about early detection and localized response and effective treatment to prevent all those complications.
And actually, again, just a perfect transition into the question that I had for Pat Wang. Welcome and thank you. As the CEO of Health First, transformative health industry player and partner representing almost 2 million New Yorkers, would love to get your take on what this translation, and I'm going to call it true partnership, because each of you spoke to the idea that this isn't CFA delivering to, but instead delivering with the health system. Talk a little bit about how you vision that.
Thank you. It's a great question. And just to echo some of the comments that were made earlier that really resonated with me, I think CFA, congratulations, it's incredible. I view it as single source of truth. We really need that. We've been looking to the CDC and have quoted, we follow the science, we follow the CDC, and that is going to be even more robust now with the CFA, so it's terrific. I think that the answer to the question that you posed at the beginning and the specifics that you articulated just now, it may not be a CFA responsibility to make sure that the good work that it does translates into change on the ground. I think, you know, a multi-sector collaboration and communication is what's essential. The federal agencies that Mark mentioned, but also local government, state government, local organizations. And on the specific question of health equity and serving vulnerable populations, I think what's critical for us all to internalize and remember is that sort of tackling those issues and closing gaps is a team sport that is played at the hyper-local level. So I don't think it's one size fits all, but it's important to remember that there are a lot of entities that are on those teams at the hyper-local level, block by block, language by language, et cetera. Health First is a not-for-profit health insurance company with close to 2 million members, 1.2 million Medicaid members, a couple of 100,000 low income Medicare Advantage members. Among our membership, we have 500,000 kids. The thing that we would do, what we did do during the pandemic, and what we would do by being included at the table with early information and the single source of truth alignment,
Health plans have a lot of data. It's because we pay claims. What we do with that data is understand our members' risk needs and what puts them at risk for different things to try to tailor approaches for them. During the pandemic, what this could have resulted in a little bit earlier, because we were also scrambling at the end, was, for example, to anticipate healthcare needs. What health conditions, which we know very well about our members, puts them at greatest risk for disease should they catch this? What do we need to do to sort of target communications to them and other interventions with their providers to make sure that they try to stay safe? But there are other health needs, maternal health, pediatric immunizations, making sure people get their maintenance medications, which also are a priority in a situation like this. There are also social vulnerability issues that emerge very quickly. Loneliness, which of our members are most likely to lose an aide in the home, or the daughter who used to come take care of her because now they're not coming out. And what do we need to do to intervene there? Food insecurity happened very, very quickly in our environment, which is, we're based in New York City. We're very hard hit very early. The shredding of the social safety net and those supports for our members was shocking, the speed at which it happened. So things like forecasting, and that's what we did with our partners and our analytics. We worked with food banks to identify food deserts where it would be logical to stand up food pantries. So early information and full data, and being included, I think, as a partner with the understanding that we're not a public health agency, but we do, through communication, omni-channel targeted communications, and a great understanding from claims-based data of sort of our members' needs is very important. So I think we are a particular type of health plan. The observation that I would just leave with folks is to remember that probably 80% of Americans are covered by a private health plan. So excluding Medicare fee-for-service, the VA, et cetera, private health plans have a huge role to play, in my view, based on the capabilities that I mentioned that they may deploy differently. Thank you.
Thank you. And Dr. Loretta Christensen, Chief Medical Officer at the Indian Health Service. What else can I ask you but how critically important it is for us to lean into the learnings that you have from the Indian Health Service, who is primarily responsible for the care of most American Indians and Native Alaskans.
Yes, thank you so much. The Indian Health Service delivers comprehensive health care to 2.56 million American Indians and Alaska Natives from 574 federally recognized tribes. It was certainly known to us prior to the pandemic that we had challenges from all the social determinants of health and significant health disparities. And as we knew and predicted, we would be disproportionately affected in the pandemic. However, I will say though, from sometimes those who have the least actually do incredible things. And we work very good with our tribal leaders, our communities, our federal, tribal, and urban sites to create an excellent response to the pandemic, which I know saved lives across Indian country. But it brings to mind how important that we need these partnerships. We need to be inclusive and collaborative, because where an early warning system is very, very critical to us, because we have challenges out in the rural country. And I want you to imagine the vastness of Alaska, a 27,000 square mile Navajo reservation. And it is not only just rural, it is extreme rural. And we have found ways to deal with that we can share with you in our part of this partnership. But early warning gives us time to mitigate. We have longer supply issues for delivery, even just to get a box from here to there. We know that we need the vital supplies. We actually ran out of oxygen in some places. Our suppliers had no oxygen left. So we had to get backups on backups to try to get the supplies we needed out to Indian country. And we need to have transferability to tertiary centers where we cannot provide that critical care. early warning, early predictions and forecasting. We did use models available at the time and we extrapolated quite well. And we feel like we were ready, but what a gift to have this as a modeling system across the country. This really gives us the heads up far ahead of time so we can prepare. We can repurpose our staff, which we did quite often. We check the competencies, we trained non-traditional vaccinators. We've pretty much created everything that you can create out in rural country to meet our needs. But the more warning we get, the more information that is shared with us, the better we can prepare. And for our part of the partnership, I think we can tell you how we communicate across Indian country, indigenous communities, and even rural areas. We don't communicate the same way. We don't have broadband everywhere across Indian country. We use old-fashioned radio stations. We use our community health workers to get the word out. We use posters and our healthcare facilities put up these billboards that say, get vaccinated, do this, do that. For those that have broadband, we do live Facebooks. We try to communicate through all the media that's possible, but as the point was made on another panel, there is an inequity in communications that we do have to solve, but I think we can give you a lot of insight into that as we create these systems across the country. Public health, vitally important. It is absolutely imperative for us to improve our infrastructure in an effective and sustainable way. You have to also understand in our very smallest communities, we don't have police stations. We don't have fire departments. There are no emergency preparedness personnel that just come with those communities. So it's incumbent upon us to work in partnership to develop these hubs so that we can then oversee all of our smaller communities that don't have emergency management systems and help them to be prepared. We need to establish them, we need to train them, and then we need to sustain them. And we definitely would benefit from the partnerships that I see in this room today. So I think there is so much applicable across Indian country. We very much appreciate the inclusion, but I think we have to continue to widely collaborate. Effective connectivity between us and all the other entities and agencies that we appreciate the efforts that were made across Indian country during the pandemic, and that we have to be also hooked into the data systems because we have had quite struggles of getting our data due to no unified database and interoperability of that data across Indian country. We did miss a lot of people that we would have liked to have identified and tracked through the system. So transparency, communication, equity, these are all resonant for me. And I think these are great goals as we all moved forward together in establishing an effective public health infrastructure. Again, thank you for the opportunity to be here today.
No, thank you for some of those lessons learned from the challenging circumstances that you described. I've had all the fun asking all the questions, so let me open it to see. We have just a few minutes left. Does anybody have any questions? Oh, perfect. Sorry.
Thank you. Thanks so much for this panel. It's funny, I'm listening to this, I'm going off topic because strengthening the system for Americans, I'm thinking about what you're saying for strengthening the system for the world. And I'm particularly struck, Dr. Christensen, by what you just said. When you think about the partnership and the feedback, the opportunity to share your insights about your extreme rural with the extreme rural of low-income countries around the world, when they're still in that phase one of the acute phase of the COVID response, is really, really important. And so we've got to figure out how we can get that feedback loop of you also feeding into CFA, thinking about the global response, reaching the last mile of people around the world. I'm also curious for the broader panel. We've heard a lot about the providers, that two-way connection with public health and the communications piece of this. What we haven't heard as much, and Mark, you touched on it briefly, was also how all of this data is going to inform innovation of other medical countermeasures. And I'm just wondering if you can think about not just how is the CDC engaging with product developers, drugs, vaccines, and of course diagnostics, but then how is the sort of the broader provider community also saying, okay, this is what we're seeing with patients, or this is what the frontline health workers are experiencing, and we need to adapt the tools we do or don't have because this is what the situation is. I'd love to hear your perspectives on that. Thank you.
Yeah, just on the last point, I completely agree. And you know, there has been a lot of innovation using so-called real-world data systems from Israel, from systems like Kaiser and others that are set up to track their patients longitudinally, been very informative about different kinds of countermeasures and how well they're working as the variants change, subpopulations, and so forth. I think we can do a more systematic job of that. There are many healthcare organizations that would like to participate even in randomized clinical trials, say of repurposed agents. We saw an effective approach to that in England with Martin Landry's trial group. And I think all of these steps really just reinforce the changing nature of healthcare public health collaboration in the ability to use biomedical technologies much more quickly in a pandemic. And just very briefly on your first point, we still have, and our colleagues at Duke do a lot of research on tracking this, some big disparities in vaccination, but now extending to testing, treatments, everything else that's needed for this very challenging pandemic management around the world. So I hope we can accelerate more equity steps there too. I know the administration's planning an upcoming summit to help with that.
Did anyone else want to respond? What I can go, and then there's someone over.
Could I just build upon that?
Oh, please,
before-
yeah.
Thank you. Just to build upon a comment that I made earlier, but I think you're touching upon it. It's worth elaborating upon. So when we think about other countermeasures like testing and quarantine and isolation, the speed of the response of the test is absolutely critical. Now we know that. We've learned that a 10-day turnaround time for a PCR doesn't do much good, and we've all lived through that phase of the pandemic. But even a 48-hour turnaround time for a PCR is grossly inadequate in a high-risk residential setting. So we need to tailor the testing strategy to the setting and the risks associated with it. And that's why it needs to be more dynamic and more responsive to the local experience on the ground.
Thank you. Then we have a question here, and then Ann will come to you.
Thanks. We're in the White House. We often talk about how all politics is local, and I feel like the theme here, both of this panel and the last one, is all outbreaks are local. You have emphasized, I think all the way from Dr. Walensky's point, that central to equity, central to preparedness, central to response is a more community-based approach. I've seen in Alaska what the Alaska Native Health Service has done. I've seen in Massachusetts what the local community-based organization funded by the CDC have done to improve vaccination rates. You've all emphasized that here. I'm curious, some of us who work in the executive office of the president would like to know, if you had the president's pen, if there was one policy you could create or change to enable more of that community-based approaches to preparedness and response, what would it be?
Don't all y'all jump at this at once.
I don't think there's one, but there is so much alignment now between what some of these local public health responses are trying to do: early detection, vaccination, treatment, et cetera, especially for high-risk vulnerable populations, and what health plans and healthcare organizations like PATS and others are trying to do. You all set up some metrics related to how well you are vaccinating your high-risk patients, and I expect now we're tracking things like access to therapeutics. It's something that's not happening as systematically as it should. Just recognize there's exact alignment between what healthcare organizations are trying to do and what some of these local public health efforts are trying to do. And if we could have more data sharing and more alignment in supporting those responses, that'd be better. I think that's your point, was along the same lines.
I have a specific one. I don't know if this is the be all and end all. It was very helpful for us once vaccinations started rolling out, when Medicare made available the vaccination status of our members. We do not have access to immunization registries to understand the vaccination status of non-Medicare members. And I think that it would be extremely helpful to develop whatever data sharing protocols are necessary to make that available, because what we did with that information for our Medicare members was our care managers went into full gear. We also, health plans have omni-channel methods of communication. We try, it's a business imperative not to get your members really irritated with you because they're getting, message after message after message and it's not relevant. So I think a lot of health plans have spent time tailoring the type of messages, also language appropriate, timing, is it text, is it, what's the person's preference, access to immunization status beyond Medicare would be incredibly helpful. The other thing that I'll mention is in terms of the communications, things that were set up rightly to protect privacy, opt-in requirements, for example, for text and automated phone messages can be a hindrance in a time of an emergency because you can't reach somebody that is in a situation and needs something. So those would be two specific areas.
Well, I'm going to go big or go home. I think public health has to be the priority for this country. The resources, the funding, the education, and the sustainment is vital to us as a nation. So that would be my ask, is that public health is our priority. Of course, I'm going to add with equity, always with equity.
Well, you inspired unanimous response. Go ahead.
So just a brief additional comment, because I don't want to repeat, but I'd love to echo everything that was just said. But one thing that hasn't been acknowledged at any point this morning, and I want to make sure this comes across the right way, is the burden of public health reporting, the burden of reporting from a healthcare provider's perspective. It is burdensome. It is necessary. We need to expect it from the healthcare system, but it is burdensome, and we need to be sensitive to that. And specifically, we need to reduce the redundancies and the duplication and the conflicting means of reporting. So if I could wave that presidential or congressional magic wand that you alluded to, it would be to standardize so that multi-state and national organizations can do a better job and not consistently struggle with all the inconsistencies.
And then getting more back when you do report in.
And last question.
Yeah, I so appreciate this conversation and everyone being here, and echoing many of the things that were said. I love seeing public health and healthcare coming together in so many ways. I felt like during this pandemic, it was like swimming upstream with like weights on your ankles and wrists. And that was the burden of IT and data in that space and thinking about the ways to move forward. I completely agree with your 3 points on like the fact that we have to have bi-directional information. So as a state chief medical officer in Alaska in the space that you're trying to figure out what this looks like, having that space is incredibly important. And thinking about, we'd often turn to our healthcare sectors to understand better, what does the PPE look like? How do you have this data? But we didn't have any of that. We put National Guard in our state lab to be able to enter a positive test for a year. We entered faxes until we were all blue in the face, had no ability to see this pandemic, but we're trying to make policy in that space. So I think that it's amazing to see this organization get together, but how do we make sure that we have bi-directional information sharing? How do we make sure that we truly have governance and data? It's really hard to be able to message the public, well, this doesn't apply to rural America. This doesn't apply to you. And so how do we make sure that we can really see the me with inside the we of the data sets? And we have such a beautiful, diverse geography that we have to make sure that that me is able to be seen for actionable items. And then how do we make sure that, 34% of healthcare is paid for by Medicare and Medicaid? There's a lot of data in there, and there's a lot of places in there. And how do we not have every single state trying to reconnect with that in a different way? We created as a country in 1986, EMTALA, to say, you shouldn't show up to an emergency department and not be able to be stabilized for your emergent medical condition. We will stabilize you. We will find a place to treat you for an emergent medical condition. How do we say the same thing as a country, that there is basic data health elements as part of public health that we have to move forward? And so how do we engage to be able to make those changes? So thanks.
Well, I think that's a great topic to build on coming out of this conference. These problems in some ways are technical, right? We have interoperability standards. We have the data is being collected. It's just maybe not being collected and shared consistently. And I guess my experience in government programs and elsewhere is that the more that supports and incentives and regulatory barriers can be aligned, or in the case of barriers removed to support those goals, the better. Seems like there are a few clear needs that have come out of this, so that the timely information sharing in and back about when there's a new outbreak locally that could inform like that local weather forecast that Ashish talked about. We didn't have that back in the first quarter of 2020 and had to have national steps as a result. Now that we have not just vaccines, but treatments and rapid diagnostic tests at scale, boy, there's a lot that I think would motivate healthcare providers if they were able to share data and it was translated into rapid access to those supports that they need. And then just, I think more things like CDC is trying to do, and I know CMS is trying to do, is like shift the way that we pay for healthcare into public health to focus on these important outcomes together.
First of all, congratulations on the excellent job that you did in Alaska. Secondly, excellent points. And it just really speaks to the point, we can't be episodic or reactive. We have to be proactive in setting up all of these systems so that we can track data in a pandemic and every day. We learn so much from sharing and being partners in this, in healthcare and public health, that it's just critical. So thank you so much for those comments.
Just add to put a plug in for interoperability. It's a very, very big foundational move. So, you know, pedal to the metal on that.
So let me thank everyone on the panel for being profound and provocative. And thanks to everyone in the room for your excellent questions, and to those that responded so quickly to such tragic circumstances with the pandemic to create a preparedness platform for us with CFA for the next. Thank you.
Great. I wish this could go on forever. I know we have to finish. Will you humor me for a second, though? There are people in this room that were truly on the front lines, are going to go back to the front lines every day, public health response, taking care of patients. They're the heroes of this pandemic. They're live streaming in as well. Can we do another round of applause for them? So, and we have another example who is, Dr. Sandra Ford has the difficult mission of bringing us home in a very short period of time. She is part of our White House Domestic Policy Council, part of our White House family. She is a special assistant to the president for public health and science. Prior to assuming this new, very important, influential role in our administration, she held a number of public health leadership positions in Georgia, most notably the district health director of DeKalb County. Did I do it right? I know my Georgia friends are watching. So, all right, DeKalb County, chief executive officer of DeKalb County Board of Health. While Dr. Ford served in District Health Director of DeKalb County, she also served as the Interim District Health Director for Fulton County, population over 1 million during the COVID-19 pandemic. Thank you for that service, and thank you for bringing us home.
Wow, 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 wow. So knowledge is power, yes? Yes. The more we know ahead of time, the better we're able to respond to the unexpected. I want to thank you for coming to the White House Summit on strengthening the nation's early warning system for health threats in support of the launch of the nation's Center for Forecasting and Outbreak Analytics. The Biden-Harris administration made a day one commitment to better prepare our nation to combat future health threats and to build a strong foundation that places the most vulnerable and underrepresented families and communities at its center. Better information leads to better decisions that can stop outbreaks before they become pandemics, thereby saving lives, minimizing economic and social disruption, and preserving our way of life. The discussions today remind us that our future is stronger when we can work together to achieve the goals of improving public health, data, and analytics capabilities that are needed to build accurate, timely, and credible predictions. And when we can build trusting, long-term relationships with decision makers at all levels of government, state, local, city, tribal, and territorial, as well as our civil institutions such as schools, employers, and community leaders. Building that trusting relationship includes, in the informing part of this, making sure that we communicate in a way that everybody understands what we're trying to say. And that's part of the equity of this. Our guests today have shared their stories over the past 2 years and reminded us of the perseverance and commitment of those gathered here, and so many of us who have been on the front lines of this pandemic. Understanding these lessons learned will prepare us for the future. Thank you to my colleagues at OSTP, specifically Dr. Alondra Nelson and Dr. Matt Hepburn for hosting this critical event today. I want to thank our moderators for these extraordinary panelists for leading us in such lively and productive discussions. And finally, to our guests both here in person and those that have joined us virtually today for spending your morning with us. Predict, inform, innovate. Thank you so much.